welcome to the deep dive. Today we're tackling something pretty serious in vascular health. Visceral artery aneurysms, VAAs.
That's right.
We've got a study here we really want to unpack. It looks at, what happens when these are treated, both the ones caught early, intact, and the ones that have ruptured, which is obviously much more urgent.
Exactly. Yeah, this deep dive is centered around a summary of a 2015 paper from the Journal of Vascular Surgery, Shukla and colleagues.
Contemporary outcomes of intact and ruptured visceral artery aneurysms. Sounds important.
It really is. It compares the different ways these are handled, open surgery versus endovascular, and the outcomes. Super important for understanding how best to manage these tricky conditions.
Right. So our mission today is basically to pull out the key findings, the main insights from this research, and see what it tells us about treating VAAs.
Let's do it.
Okay, so first off, the study itself. You said it's a summary of a paper.
Right.
What kind of study was the original paper based on?
It was a retrospective review, so they looked back at patient records done at one hospital covering a 10-year period, 2003 to 2013.
A decent chunk of time. And how many patients are we talking about?
They included 261 patients in total. But the focus was really on the 181 who actually underwent repair.
And those were split between ruptured and intact.
Yep. 77 had ruptured aneurysms, and 104 had intact ones when they were treated.
And the main goal was comparing outcomes, right? Short-term and long-term.
Precisely. Comparing perioperative, so around the time of the surgery and the longer-term outcomes, based on whether it was ruptured or intact and whether they used open surgery or endovascular techniques.
Okay, this is where it starts to get really interesting, I think.
Yeah.
What were the big differences they found between the ruptured group and the intact group? It can't just be that one burst and the other didn't, right? There must be underlying differences.
Oh, absolutely. Some really key distinctions emerged. One big one was pseudoaneurysms.
Explain that a bit. Pseudoaneurysm.
Sure. So unlike a true aneurysm where the artery wall balloons out, a pseudoaneurysm is more like a contained leak. Blood escapes the vessel but is held back by the surrounding tissue. Often happens after, say, an injury or maybe inflammation.
Got it. So like a contained rupture almost.
In a way, yes. And these were way more common in the ruptured group. We're talking almost 82% of the ruptured cases were pseudoaneurysms.
82%. Wow. Compared to intact?
Only about 35% in the intact group. Huge difference.
Okay, that's significant. What else?
Another thing maybe a bit surprising was the size. The ruptured aneurysms, they were actually smaller on average.
Smaller, really?
Yeah, about 20.7 millimeters on average for the ruptured ones compared to 27.5 millimeters for the intact ones.
Huh. Smaller but deadlier, it seems.
Oh.
Not what you'd necessarily guess.
Exactly.
So what about symptoms? How did these patients actually show up at the hospital? What were the warning signs?
Well, for the ruptured ones, the most common thing was abdominal pain. Makes sense, right?
Yeah.
Internal bleeding. But critically, almost 30%, nearly a third, presented with hemodynamic instability.
Meaning their blood pressure, heart rate, all over the place. Dangerously unstable.
Precisely. Vital signs crashing. A clear sign of major internal blood loss. A real emergency.
Okay, so you've got these two groups, intact and ruptured, presenting differently. How were they actually treated? What were the main approaches?
The trend was definitely towards endovascular repair, going in through the blood vessels with catheters and stents or coils.
Minimally invasive.
Right. That was the initial treatment for about 2/3 of all patients, 67%.
And was there a difference between the ruptured and intact groups in terms of which treatment they got?
Yes, actually. Endovascular was used even more often for the ruptured aneurysms. About 75% of those cases started with an endovascular approach.
Versus
about 61% for the intact ones.
Interesting. So even in the emergency rupture situation, the less invasive route was often preferred.
Seems so. Reflects the capabilities improving even back then.
Okay, let's talk outcomes then. Right after the treatment perioperatively. Complications, mortality. What did the numbers show?
This is where you really see the stark difference. Complications around the time of the procedure. Significantly higher for ruptured VAAs. Almost 14%.
Compared to?
Just 1% for the intact group.
Wow. 14 times higher, essentially.
And sadly, the mortality figures were even more dramatic.
How bad?
At 30 days post-procedure, 13% mortality for the ruptured group.
13%. And the intact group?
0. Nobody in the intact group died within 30 days.
0 versus 13%. That's sobering.
It is, and unfortunately, that difference persisted. Mortality was still significantly higher for the ruptured group at 1 year and even out to 3 years.
It really hammers home how dangerous a rupture is. It's not just fixing the hole, is it? It's the whole body shock.
Exactly. The physiological insult is massive.
But the study dug deeper, right?
Yeah.
It looked at whether the type of repair, open versus endo, made a difference, especially in those critical rupture cases.
Yes, and this is a really key finding. For those patients with ruptured VAAs, endovascular repair was associated with significantly lower 30-day mortality compared to open surgery.
How much lower?
Okay, get this. 7.4% mortality with an endovascular repair versus 28.6% with open repair at 30 days.
Huge difference. More than 3 times higher mortality with open surgery in the rupture setting.
A massive difference. The study actually flagged endovascular repair as being protective against mortality in ruptured cases.
Yeah, it's huge. It suggests that, if possible, the endovascular approach is really the way to go in these emergencies.
That's certainly what the data here suggests. Big implications for how hospitals are equipped and how these patients are triaged.
Okay, so endovascular seems better for immediate survival in ruptures. What about longer term? Did that advantage hold up? How did people do years down the line?
The survival trends continued, unfortunately. At the 3-year mark, survival for patients treated for intact aneurysms was much better, about 88%.
And for the ruptured group?
Significantly lower, around 62%. So even 3 years out, having had a rupture still impacted survival considerably.
Still a big gap. What about needing more procedures? Re-interventions?
Yeah, the need for another intervention within that first 30 days was higher if you came in with a rupture. Almost 20% needed something else done soon after.
Compared to intact.
That was lower, around 8%.
But did the type of initial repair for the rupture affect re-intervention rates? Open versus endo?
Interestingly, no. For the ruptured patients, the 30-day reintervention rate was similar whether they had initially had open surgery or endovascular repair.
Okay, so endo helps with immediate survival in ruptures, but maybe doesn't necessarily reduce the chance of needing another fix soon after compared to open.
Based on this data, yes. Both survival and reintervention are important factors, of course.
Right. So let's recap quickly. Ruptured VAAs, higher risk, often pseudoaneurysms, smaller size, surprisingly. Endovascular repair seems to offer better short-term survival in ruptures, but overall long-term survival is still much worse than for intact repairs.
That sums it up well.
Now, the study didn't just present numbers. You mentioned the author, Dr. Chair, added commentary. What were the key takeaways or insights from the author's perspective?
Yeah, that's often where you get some real context. Dr. Chair mentioned the study was actually sparked by a really tough case. They had a ruptured pancreaticoduodenal arcade aneurysm, a PDA aneurysm.
PDA. Those sound complicated just by the name.
They are. They're in a tricky spot anatomically, near the pancreas and duodenum. Lots of blood vessels tangled up. Makes them harder to diagnose and definitely harder to fix surgically.
So a particularly challenging type of VAA.
Exactly. And the commentary really drove home the high mortality risk with ruptures in general, pointing specifically to those pseudoaneurysms being common, often linked to underlying issues like liver or bile duct problems, and the specific difficulty with PDA aneurysms as major factors driving that high mortality.
Makes sense. So based on all this, what did the author actually recommend? What actions or changes in practice?
Well, a big one was about early repair. They strongly recommended fixing PDA aneurysms and all visceral pseudoaneurysms early.
Regardless of size.
Regardless of size, basically saying, don't wait for these specific types to get big or cause symptoms because the rupture risk is just too high. Treat them proactively.
That's a pretty aggressive stance compared to watching and waiting for some other aneurysm type.
It is. And the other major recommendation reinforced the study findings, strongly favoring endovascular treatment as the first move for ruptured aneurysms.
Because of the better survival and lower morbidity seen in the study.
Precisely. They felt it wasn't just about being less invasive, but also that endovascular techniques, especially using good imaging like contrasted CT scans, might actually help pinpoint and control the bleeding source better in those complex rupture situations.
So it sounds like the authors were really pushing for a more standardized, maybe more aggressive, and definitely more endovascular-focused approach, particularly for these high-risk types like pseudoaneurysms and PDAs.
Absolutely. They explicitly said they hoped this work would, raise awareness and push towards changes in clinical guidelines, advocating for a team approach, multidisciplinary, and really promoting early endovascular treatment for those specific high-risk aneurysms.
Aiming to standardize care and hopefully improve outcomes across the board.
That's the goal.
Okay, let's wrap this up. If you had to boil it down, what are the absolute must-know takeaways from this deep dive?
I think, number one, ruptured visceral artery aneurysms are incredibly dangerous with high mortality. That's undeniable.
Okay.
Number two, Endovascular repair seems to offer a real survival advantage and fewer complications compared to open surgery when dealing with those ruptures. That's a critical piece of evidence.
Right.
And number three, there's a strong argument here for being proactive and aggressive, especially with pseudoaneurysms and those tricky PDA aneurysms, treating them early, likely with endovascular methods, before they have a chance to rupture.
So vigilance and leaning towards less invasive techniques, especially in emergencies and for high-risk types.
That's the essence of it.
This research really paints a picture of vascular surgery evolving, doesn't it? Seeing how these less invasive endovascular techniques are making inroads even in really critical emergencies. It makes you wonder.
What else?
Yeah, exactly. Where else in emergency vascular surgery might we see these kinds of shifts? As the technology and techniques continue to get better, what other life-threatening situations might be managed differently, maybe with better outcomes down the road? Something to think about.
Definitely food for thought. It shows how research like this constantly pushes the field forward.
Absolutely. Well, thanks for walking us through that study. Really important insights.